Thank you so much to the organizers of this amazing conference to allow me to speak today. And I love the very, I guess as the British would say, cheeky reference. So we go from Richters to Richter, but I will be focusing on bispecific antibodies in multiple myeloma. So, across the last few years, we've really discovered that we are optimizing our induction therapy by using three of the core drug classes in multiple myeloma: immunomodulatory drugs like lenalidomide, proteasome inhibition like bortezomib, and CD38 monoclonal antibodies like daratumumab. And with the recent advances and approvals of regimens such as Perseus, Griffin, Imraz, Cepheus, Ischia, the list goes on, but essentially we're shoving these three core classes into the upfront setting of multiple myeloma. And we have patients who are becoming triple class exposed, if not triple class refractory, even in the early relapse setting of myeloma. And one of the things that has become clear is that despite the last decade of regimens in relapse looking at novel combinations of CD38s, proteasome inhibitors, and IMiDs, we need to move beyond these three drug classes in relapse and consider small molecules such as venetoclax and 1114 translocated myeloma, selinexor in specific patients, as it has wonderful activity. But I think one of the biggest areas that we've come across has been the T cell redirection therapy, both in terms of CAR T cells and bispecific antibodies. At the current time in myeloma, we have a number of bispecific antibodies approved and in clinical trial, but we can classify them as either the BCMA bispecifics or the non-BCMA bispecifics. On the left side of the screen, we see the current leading candidates for BCMA bispecific antibodies in myeloma. And just a point of reference, these are all BCMA CD3, so T cell engagers. We note that in the last 15, 20 years of myeloma approvals, at least in the US, the approvals have been for drugs given as monotherapy or in combination with dexamethasone, have shown approval overall response rates between 22 and 30%. The original approval for carfilzomib, based on the 003A1 study, was only 23%. Pomalidomide was approved at 28%. Daratumumab approved at 29%. But we see here in a more heavily pretreated group of patients, the BCMA bispecifics having overall response rates between 60 and 80%, showing them to be some of the most efficacious drugs ever approved in myeloma. Now, the bispecific antibody space is moving very, very fast. And even since this slide, there have been some updates, as alnuctamab is no longer being pursued in myeloma, and TNB-383 has been purchased by AbbVie, now ABBV-383. However, elranatamab and teclistamab are currently approved in many countries, and linvoseltamab will likely be approved in the first half of 2025. In terms of non-BCMA bispecifics, we have two leading candidates. And one important thing of note is that CD38 bispecifics have really not come into their own in myeloma. There have been a number of therapies, including ISB 1342, formerly GBR 1342, and AMG 424. Both drugs have been undergoing clinical trial, although 424 has stopped, and ISB 1342 has not shown significant activity to date. However, two additional targets which have been GPRC5D and FCRH5. GPRC5D, CD3 antibodies noted as talquetamab, which was approved in the recent year, and again has response rates of between 60 and 80%, and we'll go through some of that data granularly. And in my mind, one of the most exciting bispecifics that is still under trial, additional data to be presented at this year's ASH meeting, and hopefully approval, hopefully by 2026, will be cevostamab, the anti-FCRH5 bispecific antibody. So this really all began with teclistamab's approval based off of the Majestic-1 study. And one of the things that the last talk talked about very exquisitely is that when we use CAR T cell therapy, we do run a risk of CRS and ICONS, which can have significant morbidity and even mortality at higher grade. One of the ways that we offset the risk of CRS or ICONS is through step-up dosing with our bispecific antibodies. And here we see with teclistamab, we have several step-ups at 0.06, 0.3, ultimately up to the 1.5 mg per kg dosing schedule. This is administered subcutaneously, and step-up dosing typically be given between 48 and 72 hours apart. We did see an overall response rate of around 63%, with more than half of these patients achieving a VGPR in data that was published by Philippe Moreau in the New England Journal of Medicine. Now, the swimmer's plot here shows that not only are these deep remissions, they are quite durable. And we have many patients who are staying in remission well beyond a year, whereas standard novel therapies in this setting have provided durations of remission between 3 and 6 months. Now, one of the things that's noticed that along with these new amazing response rates is a litany of new toxicities that we must take into account. Now, of course, I really think about these in terms of acute and delayed toxicities. The acute toxicities, as we've discussed, are CRS and ICONS. And again, when you have a patient with immune suppression and hematologic malignancy, and the symptoms they develop are fever, hypotension, tachycardia, and hypoxia, this can be difficult to separate from an infectious cause, but timing very much helps. If 10 hours after your step-up dose, you have these symptoms, most likely CRS. 3 months after starting this, you have those symptoms, most likely sepsis or infection. Anywhere in between can become quite difficult. But the other issue, apart from this and general hematologic toxicity, has been overall infectious problems. We recognize that there's a multifunctional immune suppression, both from hypogammaglobulinemia, neutropenia, lymphopenia, and the T cell redirection itself, whereas originally you'll have T cells directed to fight off bacteria, viruses, and cancer, but if they're sent off to fight the malignancy, there's no one minding the store, and infection rates can be quite high. And we saw around a 75% rate of hypogammaglobulinemia. And in data that was published from our group, we showed that primary prophylaxis with intravenous immune globulin led to a 10-fold reduction in infectious complications. Now, obviously, the big question is, what can we do about sequencing these great therapies, and what do we lose? And in general, the data to date has shown about a 10% declination in response when going from one type of T cell redirection therapy to the next. So we see here data from teclistamab, and in the original Majestic-1 study, the overall response rate was 63%, but we see here in patients who had prior ADCs or CAR Ts, about a 53% overall response rate. Elranatamab was another approved therapy, and this is proved on a number of studies run by both Alexander Leshokin at MSK and Mohamed Moti over at the Sorbonne, another BCMA CD3 bispecific antibody that is administered in a subcutaneous fashion. Again, similar to the Majestic-1 study, these patients were heavily refractory with a median of 5 prior lines of therapy, many of these patients being triple class refractory, and some of them having prior BCMA therapy. The overall data does look quite similar to Majestic-1, median duration of remission of around 12 months, overall response rate around 61%, again with an impressive swimmer's plot that we can see here. Now, this in turn led to a median duration of remission of around 17 months. There are a handful of small differences between elranatamab teclistamab. Elranatamab has a shorter step-up dosing schedule, 5 days instead of 7 days. It is fixed dose, so as opposed to mg per kg dosing, fixed dosing schedule, which makes pharmacy very happy. But other than that, in terms of efficacy and toxicity, the drugs are quite similar. So again, we see similar rates of CRS, which can be as high as 70 to 90% when we give bispecific antibodies, although the overwhelming majority of this is going to be grade 1. And with ongoing studies about giving prophylactic tocilizumab, we've seen that many drugs can get that CRS rate as low as 20 to 30% when giving one dose of prophylactic tocilizumab. Now, we recognize that BCMA bispecifics are quite amazing, but one of the big things is that BCMA, also known as CD269, is expressed on other hematopoietic tissue above and beyond plasma cells. As such, hypogammaglobulinemia and infections become quite severe with BCMA, and because it's continual administration with a bispecific, that risk never goes down. In fact, it continues to go up. So other targets such as GPRC5D do hold some advantages in that they are not as widely expressed on hematopoietic tissue and therefore have a lower rate of infectious complications. The two key assets that have been investigated have been talquetamab and furimtamig. Unfortunately, in recent days, it was announced that furimtamig will no longer be pursued in myeloma. So at the moment, we're left with the talquetamab bispecific antibody, which is an extremely effective drug. But the other issue to note is that there is additional expression of GPRC5D on other tissues of the body. Notably, it's expressed on the squamous epithelium of the hands and feet, the lining of the oropharynx, salivary glands. So the main toxicities are skin and nail toxicities. Patients get a desquamating rash, which to me looks just like the rash from capecitabine, Xeloda. But perhaps a bigger issue is the dysgeusia, anorexia, loss of taste, loss of appetite that patients have while utilizing this drug. The drug was approved based off of the Monumental 1 study published in the New England Journal from Ajay Chari. And again, just as with the other bispecifics, there's a step-up dosing schema. However, this was approved with two different step-up dosing schemas. One takes you up to 400 micrograms per kilogram, at which point you can continue weekly dosing. Alternatively, you can give an additional step-up dose, bring patients to 800 micrograms per kilogram, and dose them every other week. Again, very heavily pretreated group of patients. Many of these patients had aggressive prior therapies, triple class refractory, many of them penta-drug refractory to lenalidomide, pomalidomide, bortezomib, carfilzomib, and daratumumab. Some of these patients even having prior BCMA therapy. Now, overall, we saw some of the highest response rates we've ever seen in bispecific antibodies, up to over 73 to 74%, with an extremely impressive duration of remission. And again, we can see this across the board. Now, we note that whether or not you choose the 400 microgram or 800 microgram dosing schema, we saw impressive progression-free survivals, upwards of over a year in some of the studies. One of the things that's quite interesting about bispecific antibodies is that the toxicities of these drugs do not appear to be dose-related, but schedule-related, meaning bringing the dose down from 800 to 400 does not seem to improve toxicity, but extending out the dose from weekly to every other week to monthly seems to mitigate many of the adverse events of our bispecific antibodies. Again, just as we've seen in some of the data from the Majestic trials, for patients who received talquetamab who had prior T-cell redirection, we see about a 10% declination in response rate. So whereas the original Monumental 1 had a 73% overall response rate, here in patients with prior T-cell redirection, we see around a 63% response rate. But again, these patients are still maintaining duration of remission for about a year. Now, again, the main issues that we see with talquetamab are very similar to that of the BCMA bispecifics. We see CRS and icons. In general, CRS with bispecifics, due to their step-up dosing schema, is grade 1 and grade 2, with the overwhelming majority of this being grade 1. And again, giving tocilizumab, especially with its long half-life, will not only reduce the severity of CRS you have now, but prevent recurrent CRS later on. ICONS tends to be a very rare event in the clinical trials with bispecific antibodies. However, it is important to note that in commercial use, we are putting far sicker patients on these therapies than would have been eligible for the original Monumental 1, Magnetism 1, and Majestic trial. In turn, in clinical practice, when you put patients on with very aggressive disease, bulky disease, extramedullary, CNS disease, we see higher rates of CRS and definitely higher rates of ICONS. So aggressive management is really necessary for those patients. Now, to me, one of the most exciting bispecifics out there is the cevostamab study, notably in KAMA1 and KAMA2. And this is the FcRH5 CD3 bispecific, whereas FcRH5 is widely expressed on plasma cells, particularly malignant plasma cells. Now, one of the things that has been an issue in the relapse refractory world of myeloma is that all therapies are to be given in design until progression or intolerance. However, the cevostamab study, specifically CAMEL-1, was designed for fixed duration therapy. After the initial step-up dosing, cevostamab is administered intravenously once every 3 weeks for a total of 17 cycles and then stopped. Patients are then observed off of therapy and they have the option to be retreated at the time of progression. And every 3 week dosing for 17 cycles, along with the step-up, is approximately 1 year of therapy. And besides seeing impressive response rate, we're starting to get an inkling into what it looks like when we stop patients with T-cell redirection therapy, allow their T-cell repertoire to recover, and then treat them again at the time of relapse. Small numbers, but we are seeing the ability to recapture, although the response appears to be muted compared to their original response rate. Now, data that was presented at this year's EHA meeting by Shachi Kumar has focused on the role of cevostamab as a post-BCMA therapy, whereas BCMA seemed to look at the post triple class, now FCRH5 looking at post quadruplet class, including the BCMA therapy. And what was quite impressive about this data was that we see that the overall response rates in post-CAR T patients was 73%. And now that BCMA CAR Ts are moving further and further up, currently approved in first relapse based off of the CARTITUDE-4 study, and likely at some point to be approved as part of our upfront therapy based on studies like CARTITUDE-5 and CARTITUDE-6. There is a possibility that we will have patients relapsing after first relapse or even initial therapy, progressing beyond BCMA. And the big question is, what is the next line of therapy? And seeing a 73% response rate in cevostamab in that group is going to help us out in the coming years. Now, in myeloma, all we do is combine therapies. We love to combine because if one drug is good, two is better, and now we love 3 and 4 drug combinations. Well, one of the first areas that looked at this was the MajesTEC-2 study combining teclistamab with daratumumab, and this was done in an earlier line of therapy with 1 to 3 prior lines. We noted that the response rate here is quite impressive at 93.5%, but it is important to note that the combination of CD38 and BCMA-based therapies can impart significant immune suppression. Data from our site during the COVID pandemic showed that the 2 biggest predictors of myeloma patients not being able to form antibodies following COVID vaccination were anti-BCMA therapies and anti-CD38. As such, we see all-grade infection here is over 90%. So this is a very potent combination, but needs to be met with the appropriate prophylaxis, including antiviral prophylaxis, regular vaccination, and prophylactic intravenous immune globulin. Now, the TRIM2 study sought to use talquetamab with daratumumab, and the benefit here is that there's a lower rate of infection with the GPRC5D bispecific antibodies. We can see here at the 800 microgram dose, response rates of over 84%. And again, this is a very potent combination and maybe a better combination for patients who are progressing on or after BCMA-based therapy, because we note that it takes around 4 to 6 months for cells to re-express CD38. So you can imagine a time where patients get Dara RVD up front, go on to receive a BCMA CAR T, and at the time of relapse, this may be an appropriate line of treatment. Now, some of the most impressive data that I've seen and we've used in clinic is based off of the data presented by Jeff Mattis from Colorado Blood, looking at the Monumental-2 study combining talquetamab and pomalidomide. And here, we interestingly use pomalidomide not because of its myeloma cell kill, but for its immunomodulating properties. And in clinical practice, giving 2 milligrams of pomalidomide not only reduces the incidence of cytopenias as opposed to the 4 milligram full dose, but here we're using this to augment the T-cell response that's induced by the talquetamab. At the 400 microgram dose, we saw a 94% response rate, which is extremely impressive in the relapse setting. So really need to see longer follow-up with more patients, because so far these are small studies. Now, if we give one bispecific and it's good, what about giving multiple bispecifics? And this has been seen in the Redirect-1 study, which has been presented by Yael Cohen and Mary V. Mateos, who would give talquetamab and teclistamab, and note that the dose of teclistamab is a bit higher than the current approved dose. It doubles it up to 3 milligrams per kilogram. This is an effort to improve the PK/PD data about extended dosing schedules. In many ways, we can get this up to once-a-month dosing. Now, this has been an extremely effective regimen, including response rates of over 96%. Where it seems to have particular efficacy is in the setting of extramedullary secondary disease. Now, this is in some of the hardest disease to treat, myeloma that lives outside the marrow. But in a sub-cohort of the redirect study, we showed over an 86% response rate in patients with extramedullary myeloma. So this type of aggressivity may be needed for patients who present with numerous plasmacytomas. Now, really, at the end of the day, symptom management, toxicity management is key to success with bispecific antibodies. And here we see a list of the rates of infections across the different trials. And again, most of these are monotherapy, but once we start combining drugs, we do have a risk of increasing infection. Particularly focusing on regimens such as single-agent teclistamab had not only an overall infection rate of around 76%, but a grade 3 or higher infection rate of 45%. So it is not uncommon to have to deal mostly with upper respiratory tract infections, pneumonia, and bronchitis with anti-BCMA bispecifics. So we need to prophylax with IVIG to markedly reduce this. The other issue is the utilization of white cell growth factors can help prevent high-grade neutropenia. There's a question of using with caution in that patients who are receiving step-up doses with bispecific antibodies who have not yet had CRS and received tocilizumab, you may run a risk of propagating CRS with white cell growth factors. However, once tocilizumab is on board, the risk of this is essentially zero. Now, CRS grades can be quite profound, and in many of the studies, CRS rates were as high as over 90%, albeit the majority of this was grade 1, grade 2. Now, there have been a few areas where we've seen improvement in CRS. Linvoseltamab has shown some of the lowest rates of CRS, between around 30 and 40%. Additionally, there have been a number of studies looking at giving prophylactic tocilizumab. And in the cevostamab study, the E1 cohort presented by Suzanne Trudel, prophylactic tocilizumab reduced CRS rates from around 96 to 30%. And in the Majestic studies with teclistamab, prophylactic toci reduced CRS rates from around 76 to 25%. Overall, it's important to note that besides CRS, ICONs, infections, cytopenias are certainly seen across the board. And additionally, anytime you're activating T cells, we do run the risk of not only CRS and ICONs, but also once the cascade is set off, we see activation of macrophages and macrophage activation syndrome, and even HLH has been seen. There's no clear pattern. However, it does appear that patients with higher burden disease will have higher risk of having some of these difficult toxicities like HLH, macrophage activation syndrome. The difficulty is, how do you debulk a patient prior to a bispecific? Because if you use classical chemotherapy and give a regimen like DCEP, those therapies are T cell cytotoxic, and then you may not have a good response with your T cell redirection therapy after that. So really, how do we prevent all of this? We try to mitigate cytopenias with standard supportive care. We recommend primary prophylaxis for hypogammaglobulinemia. This is different from daratumumab, where we wait until you have an infection. We start right in the beginning. The one caveat is that if you have IgG subtype myeloma and you're starting a bispecific antibody and your IgG is very high, you need to hold off on IVIG to reduce the risk of hyperviscosity. But once the IgG comes down, it should be started as soon as possible. Make sure patients get HSV and PJP prophylaxis throughout their treatment. Make sure vaccinations are up to date. Very controversial about whether or not to provide bacterial prophylaxis during the initial dosing. Our standard of care is not to provide antibacterial prophylaxis. However, for patients who suffer from prolonged neutropenia, it may be worthwhile to provide either bacterial prophylaxis or fungal prophylaxis, but routinely it is certainly not necessary. The biggest things is vaccination up to date and IVIG. And with that, I will thank the audience very much for listening and happy to take any questions.